Hello, my name is David Murray. I'm the NIH Associate Director for Prevention and Director of the Office of Disease Prevention. I want to welcome you to Part 6 of our course on pragmatic and group randomized trials in public health and medicine. Part 6 focuses on a review of recent practices used in group randomized trials. This is part of a free 7-part and self-paced online course presented from NIH. We provide the slides for each of the modules that you're watching, a complete set of readings, and a set of guided activities for each of the modules. The target audience for this course includes faculty, postdoctoral fellows, and graduate students interested in learning more about group randomized trials. We're also interested in having program directors and program officers at NIH view the materials so that they can learn more about group randomized trials. Participants should be familiar already with the design and analysis of individually randomized clinical trials, or RCTs. Participants should be familiar with the concepts of internal and statistical validity, their threats and their defenses, and with certain analytic methods, including linear regression, analysis of variance and covariance, and logistic regression. The learning objectives are shown here. At the end of the course, we want you to be able to discuss the distinguishing features of group randomized trials, individually randomized group treatment trials, and individually randomized clinical trials. We want you to be able to discuss their appropriate uses in public health and medicine. And for group randomized and individually randomized group treatment trials, we want you to be able to discuss the major threats to internal validity and their defenses, the major threats to statistical validity and their defenses, the strengths and weaknesses of various design alternatives, and the strengths and weaknesses of various analytic alternatives. We also want you to be able to perform at least simple sample size calculations for group randomized trials. Finally, we want you to be able to discuss the advantages and disadvantages of alternatives to group randomized trials for the evaluation of multi-level interventions. The course has 7 parts. Today we're going to focus on Part 6, Review of Recent Practices. And that presentation for today is based on a paper that just appeared earlier this year in Preventive Medicine, in which we reviewed group randomized trials published between 2011 and 2015. There have been several previous reviews of the literature in group randomized trials. The first was published by Alan Donner and his team in Canada. It was published in 1990. And they reported that only 19% of the published literature took the interclass correlation into account in sample size calculations. Only 50% of the published articles took it into account in the data analysis. His team also published a paper in 1995 and reported very little progress, the same proportion taking the interclass correlation into account in sample size calculations, and a slight improvement in terms of data analysis. We published a paper in 2004 and didn't see any real progress, 15% taking the ICC into account in the sample size calculations, 54% in the data analysis. We published another review in 2008. There was some progress with sample size calculations. It rose to 24%, but there was actually a decline in the proportion of papers that took the interclass correlation into account in the analysis. It dropped from 54% to 45%. So as we approached this most recent paper, we wanted to find out if the situation had improved. We looked at cancer-related studies that use group randomized trials designs and analytic methods published between 2011 and 2015. We conducted a Medline and PubMed search. The studies to be eligible had to have as their primary outcome cancer risk factors, cancer morbidity, or cancer mortality. They had to use randomization to assign identifiable groups to study conditions, with observations taken on members of those groups. Where the paper referred to an earlier design article or design paper, we also reviewed that article. Each reviewer, and we always had 3 working on each of the papers, independently assessed the article in terms of design, sample size calculations, and data analysis. The reviewers then discussed each paper as a group and resolved any disagreements during that discussion. We identified 123 articles from 76 journals that met our inclusion criteria. There were an additional 39 background or design papers. There weren't a great number published in any single journal. 7% were published in Preventive Medicine, 4% in the American Journal of Preventive Medicine, and after that it was a few papers in each of a wide number of journals. We saw a continuation of the general increase in the publication rate for group randomized trials. In the original review published in the early 90s, there were 5 articles published per year using group randomized trials designs. In this most recent period, it had quintupled to 25 per year. These are the analytic methods that are often used in group randomized trials and the conditions in which they are appropriate. And we discuss this material in some of the earlier modules as part of this course. Mixed model regression methods are commonly used. Mixed model ANOVA and ANCOVA are appropriate if we only include a single time point in the analysis itself. So analysis of post-test data, for example, possibly adjusting for baseline, would qualify as that kind of analysis. You can use repeated measures, ANOVA and ANCOVA mixed models, when you have 2 time points in the analysis. As soon as you have 3 or more time points, you need to shift away from the mixed model ANOVA and ANCOVA approaches and use random coefficients models. You can also use generalized estimating equations. If you have fewer than 38 degrees of freedom for the analysis of the intervention effect, you need to correct for limited degrees of freedom. If you have more than 38 degrees of freedom, you don't have to use a correction. Finally, on this slide, we mentioned Cox regression because it started to be used now. We didn't see that in the last review published in 2008. If you have a shared frailty that's included as part of your analysis, then Cox regression is perfectly appropriate for time to event outcomes. You shouldn't use Cox regression without the shared frailty, however, if you're analyzing data from a group randomized trial. We can also use 2-stage methods where we, in a first stage, calculate some group level statistic, and in a second stage, do the analysis on those group level statistics with degrees of freedom based on the number of groups. So that approach is perfectly appropriate. And then we have a number of approaches that are either not recommended or for which the validity depends on how they're used. Using a post hoc correction based on an external estimate of inter-class correlation depends on the validity of that external estimate and often is not appropriate. The other 3 that are listed here, analysis at a subgroup level or an individual level, those approaches are not appropriate for group randomized trials, though they're still used. The 123 articles that we examined, most had 2 study conditions, so comparing intervention versus control or intervention versus comparison. 88% had just 2. We had a small fraction that had 3 and an even smaller fraction that had 4 or more. Most of the studies that we reviewed used a cohort design, so they're following the same participants over time. But 20% used a cross-sectional design where they measured different participants at each time point, and a small fraction, under 3%, had a combination of both cohort and cross-section. Restricted randomization was quite commonly used. It's something that we've been recommending for a long time. 55% included some form of restricted randomization, matching, stratification, constrained randomization as examples. The balance did not use restricted and so just used simple randomization. We see a wide variety of groups that are used in these group randomized trials. There's been a dramatic increase in the number of studies that use physicians or provider groups or hospitals or clinics as the unit of assignment, and a sharp reduction in the number of studies that report work sites as the unit of assignment. We still see a good number that use churches or community groups and also schools. The average number of groups per condition has grown over time. We now see almost half of the studies with 25 or more groups per condition. And 10 years ago, that would have been a dozen per condition, so it's more than doubled. And that's a very good development because the more groups we have, the more power we have for the analysis. The average number of members per group included in the analysis has remained generally small, with more than half of the studies having fewer than 50 members per group, but 20% are larger with more than 100. The number of time points included in the analysis, most report just 1. Now, they may have 2 time points or 3 time points in the design, but their analysis is focused on a single time point, often 1-year follow-up data, perhaps with regression adjustment for baseline. That would still qualify as 1 time point in the analysis. Repeated measures approaches with 2 time points used in 20% of the studies, and even more time points where we would use random coefficients models used in just over 5% of the studies. In these cancer-related studies, about 35% were primary prevention, another 44% were secondary prevention, generally screening studies, and the target population was undefined for most of these studies. Primary outcomes varied considerably. We had just over 25% looking at screening outcomes. We had almost 20% looking at delivery of health services, and that means looking at whether there was some change in the way that healthcare was being delivered to participants. We saw a good number of studies still looking at cancer and diet and physical activity, but fewer than we saw, let's say, 10 years ago. So an increase in screening, an increase in healthcare services, a reduction in some of the traditional risk factors. When we look at the results in terms of data analytic methods that are used, 51% of these 123 studies reported exclusively analyses based on appropriate methods. So that's an improvement from our report of 2008, improving from 45% to 51%. We still see predominant use of mixed model regression methods, whether ANOVA and COVA with 1 time point or repeated measures with 2. There are a few studies that use random coefficients models, just over 10% who use generalized estimating equations with an appropriate number of degrees of freedom, and a few studies that used other methods. When we look at studies that had reported a mix of appropriate and inappropriate methods, and that represented 13.8% of the sample, it's frustrating, at least to me, when I see these papers, because on the one hand they're doing the right thing, and then on the other hand they turn around and report methods that aren't appropriate. And unfortunately in the discussion they often focus on the results from the inappropriate methods rather than the appropriate methods. For these studies, most of the appropriate methods that were used were the mixed model regression methods and Cox regression in some cases. When we look at the inappropriate methods that these same papers reported, 94% were reporting analyses at an individual level, ignoring the interclass correlation altogether. That approach has been debunked for more than 30 years and shouldn't be used anymore. When we look at the studies that were reporting only inappropriate methods, 30%, that is an improvement. It's down from what it was in 2008. The predominant methods there were analysis at an individual level, ignoring groups, and GEE with fewer than 38 degrees of freedom and no sample size correction. Now I'm going to turn to a review of practices in individually randomized group treatment trials, and then I'll come back and summarize the work both in group randomized trials and in individually randomized group treatment trials. This work is based on a paper that Sherry Powell's published in 2008. I have been encouraging her to repeat this work so that we have an updated paper. More to come on that. There had been no systematic reviews of individually randomized group treatment trials in 2008 when we published that paper. So we searched 6 journals looking at articles that were published between 2002 and 2006. The 6 journals are listed here. We used procedures that were very similar to the ones that we used in our review of group randomized trials that I just described. The criteria for sample size and analysis methods are parallel to those that are used for group randomized trials. We found 34 eligible articles. Just over 10% were published in the American Journal of Public Health, 17% in Preventive Medicine, 20% each in Obesity and Addictive Behaviors, and they were pretty evenly distributed in years with a jump in the most recent year, 2006. We'll need to do a more recent review to see if that trend continues. As with group randomized trials, the most common design compared an intervention condition to a control condition. There were a limited number of studies that had 3 study arms and even fewer that had 4. The number of group treatment conditions was variable. 32% of the studies had just 1. So one, perhaps in this case it's going to be the treatment arm, included small groups, and the control arm did not. 50% of the studies had group treatment conditions in both arms, so both the intervention arm and the control arm. And then a small fraction had 3 or even 4 group treatment conditions. For individually randomized group treatment trials, 44% of the studies had a total sample size less than 100, so these studies tend to be much smaller than group randomized trials. The target populations were quite variable. We didn't restrict this investigation to just cancer-related studies, so many of them involved obesity, mental health issues, some cancer, some HIV studies, so the dependent variables were more variable than we saw in the cancer literature. The primary outcomes shown here also quite variable. Sample size calculations were reported at an individual level, and of course that's not an appropriate method, but that's how they were reported. In just under 20% of the studies, there was no mention of sample size calculations at all in 73% of the studies, and we didn't see any studies that reported sample size calculations done appropriately. I will note that 80% of these papers reported significant results, and I'm going to come back to that point in a moment. As we look at the analytic methods that were used, 94% reported analyses at an individual level ignoring the group entirely. That is not an appropriate method for this kind of study. When we look at the appropriateness of methods, only 1 study of the 33 that we examined used entirely appropriate methods. 32 used entirely inappropriate methods, and 1 study didn't give us enough information. So the pattern here is pretty discouraging. 94% used entirely inappropriate methods, even though 80% reported significant treatment effects. So summarizing these 2 reviews, our results for group randomized trials suggest improvement from earlier reviews. We saw a very large improvement in the sample size estimation methods. We had found 24% using appropriate sample size estimation methods in 2008, and that more than doubled to 54% in this year in the paper just published. We found 45% reporting only appropriate analytic methods in 2008. That improved somewhat to 51% in the paper that was just published. And 30% reported analyses that were deemed entirely inappropriate. The progress on sample size calculations obviously encouraging. There still is, of course, room for improvement, especially in the analytic methods. In terms of individually randomized group treatment trials, we've had warnings in the literature for at least 30 years, encouraging investigators to pay attention to the interclass correlation that can develop in these studies. Even so, the literature on the design and analysis of these studies is limited. The use of inappropriate design and analytic methods is very common. We saw 94% of the articles that we examined were using inappropriate design and analytic methods. The picture, frankly, is very similar to what the picture looked like for group randomized trials in the mid-1970s. And we're much further along in terms of calendar time. We hope that the pattern will improve with time. I want to thank you for your attention today as we've reviewed the state of the practice for group randomized trials and individually randomized group treatment trials. This is part of our course on pragmatic and group randomized trials in public health and medicine. We draw your attention to our website. The link is provided here, where you can provide feedback on the module that you viewed today. You can also download the slides, you can download all the references for the course, and you can download suggested activities for each of the modules. You can view this module again from that website. You can also view the next module in the course, which is Part 7, and covers alternative designs for the evaluation of multi-level interventions. If you have questions, please send them to grt@mail.nih.gov. and we will respond as quickly as possible. We thank you again for your attention.